serves on the Continuing Medical Education Committee. Dr. Stock is also very involved with our guidelines for the guideline development, and she is the author of the Florida Guideline for Psychotropic Medication, of the Anxiety and OCD Guideline. She also very much involved with the telepsychiatry, telephonic counseling. With that being said, we are very happy to be able to have Dr. Stock spending some time with us on a very important topic on the medication management of psychotropic medication in the primary care setting. So Dr. Stock, it's all about you now.
Okay, thank you very much, Marie, for that introduction. And I guess today I've been asked to talk to you all about prescribing psychotropic medications, presentation directed to those of you in primary care, pediatricians, or those in primary care settings. So that's what I'm going to focus on. I'm going to go through, talking mostly about medications as the treatment plan. Obviously, that's not the whole treatment plan for every patient. Obviously, we recommend psychotherapies and counseling and other sorts of things for many of our patients, but that can be a challenge to get that happening or get that started. So I'm going to focus on a little bit on medications, kind of some essential medications for you all to know about. I'm going to go through the presentation. You can feel free to put questions in the chat as we go if you want, or we write them down and put them in at the end. I'm going to try to leave time for questions, and we'll see how many questions we're getting, whether or not we're able to open it up to have people actually ask the questions or just have people put them in the chat, and we're going to have somebody kind of monitoring that to try to collect the questions together. Okay, so okay, if I get in this mode, I have to advance here. Okay, let's see.
Mention that this is being recorded.
Okay, so somebody took the controls. What's going on here? I have to take back controls to be able to advance this. Okay. All right. So this was some of the learning objectives. So some general principles. General principles for, when you're seeing patients in a primary care setting is to screen for common symptoms of mental illness, on your general intake questionnaire or whatever it is you're doing to kind of, get information. And that if there is any, you want to consider if there are mental health symptoms, if somebody endorses depression, anxiety, behavior difficulties, insomnia, whatever it is, that you first consider, are there any medical illnesses or any substance use, including medications they might be taking, that could be accounting for symptoms, and that after kind of doing that general screening and considering their medication, list, doing medication reconciliation, thinking about their medical history, then you may want to follow with a more specific self-report measure to look at those symptoms and decide what you would recommend as a treatment, and if that treatment plan includes a medication, to start low and go slow with any medications, just kind of a general principle. So as you all know, I think that, when you do, so we're going to start with ADHD. So ADHD screening, I think you all are pretty familiar with that. Obviously, we recommend that people get several informants. That can be, usually from the parent and the teacher, although it may be a daycare provider and a parent, that typically is sending a scale to the teacher, although sometimes the parent comes in with report cards where there's a progress reports where there's already notes from the teacher or emails from the teacher, and I may or may not need the results of a formal scale back from the teacher to consider that I've gotten reports from two different individuals to get started. Frequently, people use a Vanderbilt assessment. There's parent and teacher versions of that. That's used for ages 6 to 12 to get symptoms. The cut point for deciding that something meets the threshold for likely diagnosis of ADHD would be 6 or more of the inattentive symptoms, which are items 1 through 9, rated as being often or very often. So that's the scores of 2 and 3. Or 6 out of the 9 hyperactive impulsive symptoms, which are items 10 through 18, rated as often or very often. And then if you're using the full, initial screening, if you see behavior in 4 or more items that's rated at often or very often, those are items 19 through 26, which kind of go through some oppositional defiant symptoms and conduct disorder symptoms. Often for older kids, people will use the SNAP-4, which has parent and teacher versions. So, right. And everybody can be sure to mute yourself if you're not already muted. So basically, the ADHD treatment recommendations include: you get a positive screen, you do diagnosis, and then you talk to the parent about kind of what your assessment is and decide on kind of treatment options, you know. Okay, sorry, if there's subclinical symptoms or mild symptoms. So the ADHD symptoms are, you know, you're not having 6 of them that are at often or very often, then you may just want to monitor. You may provide some psychoeducation. You may recommend that maybe there's some basic, suggestions about how to structure the household, or giving the parent some reassurance. If there's moderate symptoms of ADHD, then you may want to consider medications. You may consider, a 504 plan. Or whether or not the parent needs, again, some help with some basics about how to, have expectations for the child, or how to structure their household. You don't necessarily have to. Not every child who has ADHD, not every parent needs, that kind of assistance. Usually if a child is having a lot of behavior difficulties or anxiety, we'll refer to some kind of psychological treatment, but not necessarily for every kid who has ADHD. But we certainly would be considering, stimulant versus non-stimulant based on the age of the kid and all of that. And then if the kid, obviously, if the kid has severe ADHD symptoms or has a lot of high-risk behaviors, we would be starting medications, again, deciding stimulant versus non-stimulant for this kid, and referring them, either, for psychological treatment, is the kid's, behaviors, so dangerous that they would need to go to hospital, pretty unlikely for ADHD, or referring them to a psychiatrist, although I think you all, the challenge is always, how long is the wait to get in with somebody, right? So you would probably be starting medication for moderate or severe ADHD symptoms. So obviously you want to get a baseline set of vitals, which you all probably would already have had: height, weight, blood pressure, pulse. You want to document personal and family cardiac history, basically, especially family cardiac history of sudden cardiac death or an unexplained death in somebody younger than age 40, right? We're not so much concerned about grandma who died of a heart attack when she was 79, but did you have an uncle who died at age 35 or something like that of unknown causes? That's more of what we're concerned about. That tells us there could be a family history of, abnormal electrical activity in the heart, or abnormal hypertrophy, like the Holcomb kind of hypertrophic outflow kind of syndrome. So, and that's important if we're going to start a kid on a stimulant. So if, often you might start them on a stimulant. We usually start with a long-acting preparation, something that's methylphenidate or dexmethylphenidate or an amphetamine. It's kind of your, right, oodles and oodles of different medications in each category, but there's the basic methylphenidate or amphetamines. That's how I explain it to parents. There's those two families of stimulants. They all have the same side effects. We're just kind of looking at, which one's best tolerated for that person, and kind of the duration that we need given the kid's age, ability to swallow pills, how much homework they have, that kind of things. And then, of course, there's the alpha-2 agonists. I don't know why I didn't put on here. Also, there's atomoxetine or viloxazine. So there's other medications. I guess I was thinking about medications that are most often started and are most easy to obtain on the Medicaid formulary. So and for young kids, for a young kid, you might start with, or if you're deciding to start with an alpha-2 agonist, we usually would use Guanfacine extended release, starting at 1 milligram per day, maximum of 0.12 milligrams per kilogram per day for that. So I think on the Medicaid formulary, the clonidine extended release is not covered as readily as or as easily as the Guanfacine ER. And the Guanfacine ER can be just once a day, whereas the clonidine extended release is twice a day. So you're going to get better compliance most likely with the Guanfacine ER. So, once we start treatment for ADHD, we reassess with rating scales every 2 to 3 weeks and titrate the dose until the symptoms are improved below the cut points, or if the medication is not tolerated, then we might change. If they're not responding, we get to kind of a maximum dose that we think is reasonable for their age, height, weight, all of that, then we may want to switch medications, either switching stimulant categories, or we might, we have a partial response, we might augment with an alpha-2 agonist. And obviously along the way, we monitor vital signs, we consider drug holidays if the child is having difficulty with deceleration and height or weight gains. So, just a little summary that on the Medicaid PDL, which each of the Medicaid sub-varieties may or may not exactly follow this, but on the main Medicaid preferred drug list, there's Metadate ER, Metadate CD, Concerta, Datrana, and Jornay are all methylphenidate products that are long-acting and are available. There's dexmethylphenidate long-acting, Focalin XR, brand name of that's covered. In the amphetamine long-acting, the Adderall XR brand name and Vyvanse are covered. And alpha-2 long-acting is Guanfacine. So, you have a kid who has Medicaid, you're probably going to be starting with one of those medications as far as ADHD treatment. Obviously, we're going to, if you have the kids on a stimulant, you monitor vital signs because stimulants can increase blood pressure and pulse. Not usually dramatically, it's an average of 4 millimeters of mercury in systolic blood pressure, average of 4 beats per minute in pulse, but the range is wide. It can be as much as 30 beats per minute increase or 30 millimeters of mercury increase in systolic blood pressure. So we monitor vital signs. We'll monitor for insomnia, monitor for low appetite or any weight loss associated with that. We monitor for motor and vocal tics and for mood changes like irritability or sadness, which can accompany stimulants. Some kids are irritable or sad while the stimulant's working in their system. Many kids have kind of a crash as the stimulant wears off. They've got an hour to 2 hours of a lot of irritability in the afternoon. So you always want to know if they're saying the kid has a lot more irritability, kind of when is it? Because if it's at the end of the day when the stimulant's wearing off, you can sometimes tweak that by giving a lower dose of a short-acting stimulant in the afternoon or timing an alpha-2 agonist at that point or lowering the overall dose of a stimulant. You can kind of work with that a little bit. And then sometimes the stimulants can cause anxiety. So actual worries, nervousness, but also, skin picking, hair pulling, that kind of anxiety. So that's kind of ADHD. I'm imagining you all know most of that pretty well, so I won't spend a lot more time on that. More common, I guess, is not your happy, what I call kind of your happy-go-lucky puppy ADHD kids, the kids who are just happy but off task. That's not so difficult for us to treat or for parents and teachers to manage. But we get a lot of concerns about kids who seem both hyperactive, who also are having trouble with aggression or irritability. So, obviously we start by gathering history, kind of trying to figure out, is there anything going on? Obviously, has there been any significant stressors? Was there or is there abuse going on? Has there been a traumatic event? Have there been significant household changes, siblings born, grandma moved into the house, anything like that? Any new medical symptoms, a lot of diarrhea, cramping, stomach pain, any headaches, anything else that might be going on for the kid, right? You can consider using the modified overt aggression scale. That's a free scale that's in the public domain. It's got subscales for verbal aggression, aggression against property, aggression against yourself, aggression against others. And the cut point for that is if you've got 4 points or more on that scale. But it can often be helpful to figure out with parents kind of what are we talking about? What kind of aggression is it? And to be tracking it to figure out, is that getting better? So is it improving? There's also a scale in the public domain called the Affective Reactivity Index that can be completed by children and parents ages 11 to 17. It's got 7 items, so it's pretty short. They're scored 0, 1, and 2, and the cut points are at 7. That's considered a mild to moderate levels of aggression. At 14, it's moderate to severe. So again, you can use that to kind of characterize what they're talking about, and then use that to track how they're doing once you're treating them. And there's a new scale that just got put out. It's called the Emotional Outburst Inventory. That's got 8 items, but it's much more qualitative. It's not so much about scores. It's more just characterizing what kind of aggression or outburst are we talking about for the kid. So all those are things that you could be using in the chart at baseline and be tracking with this. So again, we look for a positive screen for aggression. And you want to try to figure out what might be going on as far as diagnosis. I'll say this next, that like really aggression and irritability are not specific to any one diagnosis. There can be multiple different diagnoses, from post-traumatic stress disorder, obsessive compulsive disorder, ADHD, depression, anxiety, oppositional defiant disorder, schizophrenia, tons of different bipolar disorder. Everything could basically cause aggression and irritability. Autism, it's not very specific at all. That's why you just kind of have to characterize, what are people talking about? What are the parents talking about? What's going on? You look for any underlying disorder and try to treat that first. And kind of, you know, as you're exploring it, if it's mild to like subclinical to mild aggression, you might give the parents some suggestions. You might monitor this with some of the forms. If it's moderate aggression, you're going to treat any comorbid condition that you know is there. You're going to refer probably for parent management training or for family therapy. If it's severe aggression, you might be starting medications for that, you know, in addition to all of the referrals. You know, having said that, there's no medication that's been really specifically studied just for aggression. At least not in most cases, except for autism. There's 2 medications. So like I said, medication for aggression and irritability. Again, aggression and irritability are not diagnostically specific. It is helpful to kind of see, what are they talking about? Is this, so sometimes I ask kids like, so, you know, your mom says you get angry a lot. Like what happens when you get angry? Are you yelling? Are you, you know, saying mean things to people? Are you stomping your feet? Are you slamming the door? Do you break things? You know, do things get broken? Do you push, hit, you know, push or hit people or things or objects? So kind of trying to figure out, is the kid punching holes in the wall? You know, what's going on? So, you know, pretty often we'll see aggression and irritability that's associated with ADHD, but again, it could be autism, ODD, conduct, anxiety, mood, it could be anything. So whatever's there, you want to strive to treat that first. For kids who have oppositional defiant disorder or conduct disorder or disruptive mood dysregulation disorder, more than 80% of those kids have a comorbid ADHD diagnosis. So almost all those kids have comorbid ADHD. And when you look at kids who have ADHD and have aggression, stimulants have been shown to reduce the aggression and to improve their mood. On rating scales for mood, the mood goes up as their ADHD symptoms are treated. So really, when you think of a kid with aggression, if there's comorbid ADHD, your stimulant treatment is the first line for aggression. So you strive really, if a kid's got comorbid ADHD, to really aggressively treat the ADHD first. That typically means using a stimulant plus an alpha-2 agonist to kind of cover the whole day. You know, the kid may be doing fine with the stimulant until it wears off, and then in the evening they're terrorizing their siblings and the pets, or maybe the opposite. The morning, the first hour, plenty of parents that are saying, right, that by the time the stimulant kicks in the morning, everybody's in tears, you know, because there's just been such chaos that's happened. So we first try to really treat with both a stimulant and a non-stimulant to cover the whole day as best as we can, or thinking about which variants of the stimulants we're using, right? Because if you're using the Jornay, which is the long-acting methylphenidate that gets dosed in the evening, you know, you might be able to improve the morning symptoms. So if ADHD treatment, you know, and typically you refer them for parent management training. So if ADHD treatment plus parent management training has not improved the aggression, then we often consider using an atypical antipsychotic, adding that to the ADHD medicines. So that unfortunately means these kids with ADHD and aggression often are on 3 medicines. They're often on a stimulant, a non-stimulant, and end up on risperidone is one of the ones that's been best studied for that. There's actually several studies, or one pretty large study that looked at doing just this, maximizing the stimulant, adding parent management training, and then the kids that didn't respond after those 2 things, as far as if their aggression was still present, then risperidone got added. The only medications that are FDA approved for any kind of irritability, which is are risperidone and aripiprazole. Those 2 are FDA approved for quote unquote irritability associated with autism. In the studies, irritability was used as kind of a marker for aggression. So aripiprazole for kids with autism was started at 2.5 milligrams, 2.5 to 5 milligrams a day, depending on the kid. We usually start pretty low. We often even start just at 2 milligrams to see what does that do, with kind of a maximum of about 20 milligrams per day. Risperidone, we start pretty low, 0.25 twice a day, and kind of titrate up to from there up to a maximum of about 4 milligrams per day. So really, those are going to be our two, the two antipsychotics that may be best, for you guys to know best as far as be comfortable with using those, know how to use those medications in terms of if you're going to need to treat kids who have ADHD plus significant aggression. So while you're waiting to get them into referrals, or you're trying to figure out what to do, or you just don't have referrals in your area, Aripiprazole and Risperidone, I would encourage you to know about those. They do have side effects. Kids can get dystonic reactions. So those are like, getting a muscle kind of stuck, like a neck that's stuck in one position, having significant muscle cramps. A worrisome muscle cramp is when kids' eyes roll back on their head. It's called an oculogyrate crisis. So their eyes are up and they can't seem to move their eyes down. They have to move their head to be able to look down. So that's obviously very distressing for the child and the family. Sometimes they feel like their tongue is very fat or very thick, or their tongue is sticking out. But the kid is talking funny because their tongue is sticking out. So these don't happen that often, but a dystonic reaction you want to know about. So kids sometimes get akathisia. So kids can get restless. Akathisia is, a feeling of being unable to sit still. So the parent may say they seem like they're more hyper, like they're not aggressive, but they just can't sit still. They're more hyper. They're more moving all the time. The dystonic reactions can be helped, acutely with using diphenhydramine or benztropine, orally or as a shot if they were to present to an ER or a walk-in clinic or something. Akathisia is often countered by using propranolol. Many kids get weight gain with these medications, so kids just get very hungry and can gain weight even if they're not eating a lot more. So that's a significant concern. And if they gain weight, they can get dyslipidemia, they can get elevated blood glucose. They basically get insulin resistance from these antipsychotic medications, so they can get metabolic syndrome. So we're kind of watching for that, and kids get hungry, hand over fist. They just gain so much weight, as you got to be careful. Some kids gain no weight, but other kids gain a lot of weight. And they can get gynecomastia with risperidone, because risperidone causes an increase in prolactin, which can lead to gynecomastia. So you have to do a breast exam for boys, to palpate, make sure they're not developing breast tissue. So we're typically monitoring for all those side effects, telling families to let us know about them. We usually do baseline monitoring of lipids, CBC, CMP, and then we're doing those usually every 6 months. You can monitor prolactin, but it's not consistent as to whether prolactin gets elevated. Risperidone always elevates prolactin. So if you check prolactin levels, they will always be increased on risperidone. It increases for 3 months, peaks, and then kind of lowers. It almost never lowers back to baseline. It almost never lowers back to the normal range, but it'll be 15, 16. The problem is that just because the prolactin is elevated doesn't necessarily mean the kid gets gynecomastia, and plenty of kids get gynecomastia and the prolactin is normal. So you're better just to go with the exam. So the good thing is that the antipsychotics work for aggression usually within 2 weeks. So they're pretty quick. So you can see the kid back. I see a question about how young. I think these are both FDA approved down to age 5. All depends. Then after that, it all depends on severity. If the kid is very significantly aggressive and other measures haven't been successful. So if a kid's very aggressive in the first daycare they've gone to, I might suggest let's see if that environment makes a difference, right? If they're not aggressive at home and it's just at daycare, maybe we change daycares. But if the kid's been in a couple different settings, the aggression is similar across all settings, you've tried ADHD medicines, they either can't tolerate them or you're not getting anywhere with them and they're significantly dangerous, to themselves or others, they're biting people consistently, throwing chairs, doing things that could be harmful, then, you always have to decide when do we treat off-label, as far as the age of the kid. And so some people are asking about the use of anticonvulsants. Sure, anticonvulsants could be used for aggression as well. They often work well for hot, quick, angry outbursts, but the medicines that are best studied and are typically recommended are these two antipsychotics. So that's in the, I think now it was all the way back to 2010, 2012. There was this guideline called the TMA guideline, treating maladaptive aggression in youth, and that recommended these medications. And I think I had on a previous slide the more updated, where is it? Down here, this Connor publication in the Journal of Child and Adolescent Psychopharm in 2019. It was basically the updated TMA guidelines that kind of indicates that the best studied medications really are the antipsychotics. What's going on here? Ooh. I don't know why it's going crazy with that. Let's try to get this back under control. Yeah, so, and when we dose the antipsychotics, all depends. Younger kids sometimes need BID medications. If the kid really is having trouble sleeping, you might give it to them at night to try to take advantage of any sedation that happens. You know, I often tell them to start it at night, see if the kid is tired, see how that goes. You know, depends. If some parents are like, but he's aggressive in the morning and they really want to give something in the morning, you can give it in the morning. It doesn't really matter. And like I said, the younger the kid, the more often we have to use it BID. So we might be using Aripiprazole 1 milligram BID or risperidone 0.25 BID, something like that. Really, if you look at the DMDD, so the newer diagnosis, people often ask, well, what's the treatment for that? We really don't have a lot of studies on that. Most all the studies for DMDD are basically looking backwards at kids who have ADHD plus ODD and some mood dysregulation. And they're all basically looking at stimulants plus non-stimulants, stimulants plus parent training, all of which work only to a certain extent. Newer studies, there was one study with Aripiprazole and stimulants, and that showed improvement in externalizing symptoms and in irritability. So that was a positive study. There was the kids with DMDD seem to grow up to be kids who have what we used to call dysthymia, persistent depressive disorder, persistently negative mood. They often grow up to have some personality disorder symptoms or some substance use, or sometimes even some generalized anxiety disorder. So they often grow up to have something that looks like a depressive disorder. So there was a study looking at citalopram plus a stimulant treatment, and basically they saw improvements in mood, but actually no change in impairment, no change in functioning. So we kind of consider that a negative study. So we don't have a lot of, like, really everything for DMDD is really just looking at stimulants, optimize ADHD stimulant, optimize ADHD treatment, stimulant plus a non-stimulant, add on the antipsychotic if you have to. You know, parent management training, school programs, you know, whatever else you can do. So bottom line, treat the underlying condition first and refer, you know, have a 504 plan at school or those kind of things. And if ADHD symptoms are present, which they will be 80% of the time, optimize the ADHD treatment. So, all right, so that's kind of ADHD and aggression. So moving on to anxiety, you're going to gather history. You know, typically we'll use the SCARED questionnaire. There's parent and child questionnaires for SCARED, kids ages 8 to 12 years. The cut point is 25 for just kind of clinically relevant anxiety, and there are subscales for separation anxiety, social anxiety, and panic. There's a shorter scale because a SCARED is about 40-something questions. The GAD-7 is for kids 12 and over, and it's shorter. So if you've got a teenager who's not going to do a longer form, well, teenagers really aren't validated for the SCARED. So a teenager use the GAD-7. Cut points are score of 5 is mild, 10 is moderate, 15 is severe. So you do your screening for anxiety, you get your rating scale, and if it's subclinical to mild anxiety, we talk to them about everybody has some level of anxiety. Anxiety is helpful for us. We have to have some. It can be useful to us. If I'm anxious about a test, I study for the test. Helps me prepare. So we may just tell them to kind of keep track of their anxiety, rate it on a scale of 0 to 10, write it down, kind of keep track of it. And, you know, they were really looking for free-floating anxiety that doesn't go away when stressors go away. So if I'm anxious before a test and after the test I feel relaxed, that's probably not clinically relevant anxiety. If the child has moderate anxiety symptoms, we may refer them for cognitive behavioral therapy or any kind of psychotherapy we could get them and consider medication. Severe anxiety, we'll start medications and the CBT and any other referrals that we might need. There are no FDA-approved serotonin reuptake inhibitors for anxiety disorders, but serotonin reuptake inhibitors are typically what we would use for an anxiety disorder. So those are our first line typically is to either use fluoxetine, which is Prozac, or sertraline, which is Zoloft. We usually start 5 milligrams a week of the fluoxetine if you can. That requires getting a 10 milligram tablet, splitting it in half. Medicaid doesn't like that, so sometimes you have to just go with the 10 milligram capsule. and kind of watch at that there. Sertraline, we often take a 25 milligram capsule, a tablet, split it in half for 12.5 milligrams per week, and then go up to 25 milligrams. It depends. If it's a teenager, we're going to go up to, from 25 to 50 pretty quickly. If it's a younger kid, so really 12 and a half to 25 is probably for a pre-pubertal kid. 25 and 50 is probably for an adolescent. And fluoxetine I always dose in the morning because the majority of people, it's kind of has more of an alerting effect and energizing effect. Sertraline can be AM or PM. It doesn't really matter. It's about a quarter of people that get sleepy with sertraline. So those are typically what we use for generalized anxiety disorder, separation anxiety disorder, or social anxiety. It's these two medications. The improvement with those medications is typically apparent by 3 to 4 weeks. If you're not seeing improvement in 3 to 4 weeks, we typically would titrate up the dose if we're still on sort of a low dose. It does take 4 to 6 weeks, maybe even 8 weeks to see the full effect, but you should be seeing positive results by 3 to 4 weeks. If you're not seeing movement in the right direction, then we either go up on the dose if we've got room to go up, or we change medications. So typically we titrate fluoxetine by 10 milligrams at a time. A typical max dose for like these kind of disorders is 60 milligrams. We'll titrate sertraline by 25 for pre-pubertal kids, maybe 50 milligrams for a teenager. Max dose is 200. So if you get to a point where they either have side effects or they're not responding, you get all the way up to, max dose on fluoxetine is 60. But if I get to 40 of fluoxetine and I'm getting nothing, the kid's not responding at all, I'm going to switch medications. I'm not going to keep going. If you've gotten to 40 and there's partial response, movement, but not all that we want, we may continue to go up. Same thing with sertraline. If I've gotten to 100 or 150 and I'm getting nothing, I'm going to switch medications. So typically what you do is flip-flop SSRIs. So if one isn't working, switch to the other. Certainly if one of these medicines isn't working, you would want to add CBT or encourage them to get any kind of therapy that they can if they're not already receiving therapy. And if they fail 2 SSRIs, then we often use duloxetine. That's generic for Cymbalta, and that is a selective, it's a mixed serotonin and norepinephrine reuptake inhibitor. So that one actually is FDA approved for generalized anxiety disorder for kids ages 7 to 17. Usually start at 30 milligrams in the morning because it's a little bit activating, and after 3 to 4 weeks you can go up to 60 milligrams. So you might ask why we don't start with that first if it's FDA approved to treat generalized anxiety disorder. And really most of the studies with anxiety show that anxiety responds best to serotonergic medicines. And the duloxetine being mixed serotonin and norepinephrine reuptake inhibitor, it's just not as serotonergic as sertraline and fluoxetine. So those are still considered better medications, first-line medications, because they've got more serotonin selectivity. So those companies just have not gone ahead to get any kind of pediatric indication because they've been out for Lord knows so long. Fluoxetine's been out since 1987. So there's just nobody's going to go forward with new indications for that, or only if it was something that really has no other medicines, for it. So really anxiety, you want to know fluoxetine and sertraline, be comfortable treating with those 2 medications. You kind of, once the scores are below a cut point, you want to remain at that dose for usually about 12 months. You can reduce by 25 to 50% every 2 to 4 weeks during a period of relative stability. If you're going to taper off of it, I would really just go once a month. I don't go any faster than that. If the kid is stable, we don't need to take any risk to destabilize them. I make one change, especially because in the 2 weeks that I change it, if something stressful happens, then it gets hard to tell what was happening. And families don't let you know until they're already on to the next dose cut or so, and you just don't know what really happened. So just a month at a time. It's also easier to just give them the directions. I'll be like, for the month of June, you're going to do this. On July 15th, you have a family conference. And if everything looks good to everybody, mom, dad, kid, we all agree, no problems, no changes, then on July 15th, you can go down. So I give them a date to have a family conference or a date to come back in and talk to me. So ideally, we would do any kind of reduction in anxiety medications at a time of low stress and not near a transition. Like I would not taper a kid off of anxiety medicines in the summer now if they're starting high school in August. Wouldn't do it because that's a whole different variable. We don't want the kid to be having trouble then. So we usually do it, not right before major changes. And we monitor them after, discontinuing the medication. So we always have them come back after they're off the medicine to kind of make sure that they're continuing to do well, because it can take 6 to 8 weeks for a recurrence to show up. So, all right. So obsessive compulsive disorder, to help gather family history, gather history for this, there is this Florida Obsessive Compulsive Inventory that you can find online. There's 20 questions, yes, no. And if any of them are yes, there's a part B that has 5 questions with a cut point of 8. So that's one way to screen for OCD. And it's pretty similar, like mild OCD symptoms we refer for CBT, moderate CBT plus medicine, severe, you definitely start medication. There are 4 FDA-approved medicines for treating OCD in kids. That includes fluoxetine starting at age 7, sertraline starting at age 6, and fluvoxamine starting at age 8. So the fluoxetine and sertraline, you would start the same way you do for other anxiety. OCD used to be considered under an anxiety disorder. It's often kind of presents as a variant of worries, even though the DSM puts it in its own or in a separate category these days. But knowing fluoxetine and sertraline, that's usually what we start. Fluvoxamine is FDA approved, but it has a lot more side effects. There's more sedation with it. It's a BID medicine, so we don't use that as often. And clomipramine, which is a tricyclic antidepressant, is also FDA approved, but that has a lot more side effects: weight gain, sedation, dry mouth, constipation. So we don't usually start with that first line. So for you all, I would recommend knowing fluoxetine and sertraline. Again, once the scores are below the cut points or remain at that dose for at least 12 months, you can reduce the dose if it seems like they are doing well. Okay, so depression. There's the Mood and Feelings Questionnaire for kids ages 8 to 12. Sorry, I don't know why this, didn't realize it was doing that. There's a short version, which is 13 items, and there's a long version, which is 33 items. You can give that to parents and kids. There's a parent and child version. And then for teenagers, there's the PHQ-9, which I'm sure you guys are all very familiar with. Cut points, 5 points is mild, 10 is moderate, and 15 is like moderate to severe. So 15 is what we often use. It's got a sensitivity of 73%, specificity 98%. So mild to moderate depressive symptoms. Mild depressive symptoms you can just approach by what the Europeans call watchful waiting, or the British really call it watchful waiting, which is just kind of saying, labeling this, saying this is what this is. It's depression. We have treatments for this. We can kind of see how things are going. Ask them about stressors, being curious, having them do some journaling, having them write down a number for their mood every day. That often helps this resolve. If they've got moderate to severe symptoms, you would begin an evidence-based therapy if possible, which is usually cognitive behavioral therapy or interpersonal therapy. And you might start medication. If it's severe, you start medicine and depression. Really, for anxiety and depression, all the studies show that the combination of CBT plus medication gives you the best outcome, as compared to when they compared CBT or medicines or the combination wins out. Pretty much for anxiety and depression, similar for OCD. 2 FDA-approved medicines for depression in youth, and that's fluoxetine starting at age 8 and escitalopram, which is Lexapro, starting at age 12. The studies with escitalopram lower than age 12 did not separate from placebo. So it's not that they didn't study it, it did not separate from placebo. So escitalopram is a medicine you should use in teenagers. And typically I would start escitalopram 5 milligrams per week, go to 10 milligrams. Again, it can be AM, that one can be AM or PM, whatever they prefer. A lot of people like it at night. They feel like it helps them unwind. So that's fine. So these are the medicines for depression you should know. Fluoxetine starting at age 8, escitalopram starting at age 12. You can titrate if they're not improving by 3 to 4 weeks, titrate the dose up to 20 milligrams. You can change the SSRI or add CBT. So okay, I'll have to see about that question in a minute. Okay, just a few more things about SSRIs. So typically they are dosed once a day in adults and teens, morning for fluoxetine, morning or evening for sertraline and escitalopram. Pre-pubertal children, they can metabolize medications more quickly and they might need BID dosing. Sometimes parents will tell you, like, mood seems great going through the day and then it just seems like the medicine wears off or something. Evenings are much worse. Could be stressors and things going on at home, but if you don't find that, sometimes just dosing it twice a day, like breakfast and dinner, will help it work better. Usually you ensure an adequate trial before changing medicines. But like I said, I don't usually wait a whole 6 weeks before changing a dose of medication. Well, I usually check in with them at 3 weeks before they're going to need the next prescription to decide, are we seeing some movement in the right direction? Are we just going to hold and see how much more we get? My general rule of thumb is I need about 50% improvement by 3 to 4 weeks. If you're not getting like at least 50% improvement, I'm going to go up on the dose as long as you're tolerating it. If you're not tolerating it, we're going to switch. So other side effects to pay attention to: nausea, diarrhea, a lot of serotonin receptors in the gut. Usually, that's why we could do half doses and then go up to help them to let their body and their gut get accustomed to the increased levels of serotonin. Nausea, diarrhea usually goes away within a week or 2. Headache often also remits with time. Those are usually things that happen in the first week. Agitation, impulsivity, activation, we call that behavioral activation, happens in about 3 to 8% of kids, where they just seem like they're much more hyper. They seem like suddenly like they've developed ADHD, or like their ADHD medicines aren't working any longer, or they just seem almost manic or something. So that happens in 3 to 8% of kids. And we just stop the medication. It usually goes away within a few days. You can have insomnia, you can have fatigue or sedation, and you can have sexual side effects, including low libido, delayed orgasm, or anorgasmia. So we have to talk to teenagers about that if I'm using these medications. Can also cause some increased bleeding time. So we sometimes see some increased bruising. This is why it has to be stopped before surgeries or medical procedures. Obviously, if you're using high doses or combinations of medicines that impact serotonin, you can get serotonin syndrome, which shows up with flushing, diarrhea, autonomic instability, muscle tremors, muscle spasms, or confusion. So for that reason, we have to be careful we don't combine it with St. John's wort, because that's a mild SSRI. We don't combine it usually with MAOIs, because those are strong SSRIs, or linezolid. We also are careful with people who are taking triptan migraine medicines to tell them, if you feel these things when you're taking your triptan, like flushing, diarrhea, muscle spasms, confusion, stop, let us know. Same with ketorolac or propoxyphene. And there can be drug-drug interactions, because some of the SSRIs are strong inhibitors of various P450 systems. So like fluoxetine, Prozac, fluoxetine is this very strong inhibitor of the 2D6 system. So there's a lot of medication interactions that can happen. It can raise the blood level of some medicines. And very importantly, it can inhibit the conversion of Tylenol 3 into morphine. So basically Tylenol 3 will do nothing for somebody on an SSRI. So I think overall we just don't prescribe Tylenol number 3 anymore anyway, but certainly not to somebody on an SSRI. And very importantly, 4% of people taking an SSRI will have suicidal thoughts. In all the studies, there was like 23 studies, 2% of the patients who were getting placebo had suicidal thoughts, 4% had suicidal thoughts. So the FDA requires you to report that to the public. And usually when I tell parents about that, there was 2% versus 4%, they're very comfortable with the medication. Usually happens within 2 weeks of starting the medicine or of a dose change. Usually goes away within 1 to 2 days of stopping the SSRI. And I'll say that most kids have a sense that this isn't me, or even adults, that this isn't me, these aren't my thoughts. I don't want to commit suicide, but I can't stop thinking about it. So it's a very chemical, foreign feeling. And so you just educate the parent and the child. If anything like this happens, you stop the medicine and call me. So, all right. So I sort of already said this, discontinuing any of these medications, after 12 months of good functioning and low symptom severity, you can consider stopping the medications. If you're using any augmenting or adjunctive medications like trazodone for sleep or hydroxyzine for anxiety, we'd first want to stop that, make sure the symptoms are stable, and then we slowly taper the medication to avoid destabilizing. This is more like for SSRIs or for the antipsychotics, or maybe an alpha-2 agonist. Stimulants are much simpler. You can usually just stop those and kind of see how things go. So basically, that's the kind of summary of what I would say. As far as like the kind of medications I think you all want to know about would be stimulants and alpha-2s, which I think you know about, aripiprazole, risperidone, fluoxetine, sertraline, escitalopram. If you kind of feel comfortable with that group of medications, you're going to be able to, handle a good number of the mental health disorders or symptoms that you see in your patients. So, So I'll see if maybe Sabrina can tell me if there's questions, or if we want to have people, if you want to put other questions in the chat, or if you want to raise your kind of virtual hands. I'm not sure if I can see all those. I see one question about how would I wean off an SSRI before adding a stimulant. I guess you're assuming that I need to, or that I want to necessarily stop an SSRI. I mean, same way I would wean a stimulant anyway. I mean, if I feel like an SSRI is not working and I'm worried about medication interactions, then I would reduce it more quickly. You know, you can stop SSRIs by going down one level of the dosing, you know, like some from fluoxetine 20, go to fluoxetine 10, you know, for a week and then stop. You can do 1 week at a time to stop. We just don't do it that quickly if everything is stable. If everything is stable, we go really slowly, give their brain time, because when you lower the dose of a medicine, you've got a whole bunch of receptors in their nerve cells that are being upregulated and downregulated, and people can feel very moody, very emotional when they're stopping an SSRI, and you need to make sure that they, you know, does that stabilize? And that usually does stabilize in 2 to 3 weeks. So I usually go 1 month at a time. So if I thought that the SSRI was doing nothing and I wanted it out of their system before I started a stimulant for some reason, I would just go a little faster, like 1 week at a time. So, and then somebody's asking about Jornay. Jornay, you know, usually you take Jornay, that's the evening methylphenidate. You take that at 8 or 9 o'clock at night, and it's supposed to be starting to work in your system about 5 or 6 o'clock in the morning. So that's usually the way it's recommended. It supposedly lasts until 5 o'clock the next day. It's supposed to have like a 16-hour duration. So you take it at 8 or 9 o'clock at night. It's supposed to last all the way around. It does not do that, in my opinion, and in most people's, most psychiatrists' opinion. I usually have to give another medication in the day. You just have to figure out when. So the mornings go a lot better for kids. A lot of families say it's wearing off by, you know, 12, 1, 2 o'clock, and you just have to decide, do I give a second dose of some kind of stimulant at that point, or am I using a non-stimulant with it, or what? So I've got tons of kids that are on Jornay plus another long-acting. They're taking a Concert at noon or Vocalin XR at noon or something. So, what do I do with teenagers who stop taking the medication? Talk to them about like how they're doing, like how's this working for you? You know, what do you think about, you know, what's going on? I mean, you know, I'd say that that's the more, you know, lots of adult providers are concerned about giving stimulants to college age students because they're concerned they're not going to use them appropriately. You know, I would say that it's more often that I see kids who we know have ADHD who go to college and stop taking their medication. So yeah, so you can talk to them about what don't they like about it. There's lots of things people don't like about their stimulants. They feel that their emotions are suppressed. They feel like they're not as funny. They feel a little blunted, or they feel a little irritable. I've had people tell me I feel kind of on edge, like I'm focused, but I'm pissed. And so people will tell you they just don't like how they feel on it. So that might be a time to try atomoxetine if they haven't tried that. If there's comorbid depression, I might be using bupropion. So like, you know, for college age kids, there might be some other strategies we'd be using. Managing anxiety and depression in the same person is it can be nice because it's the same medications. So it's SSRIs that you start with typically if there's both depression and anxiety. So then you would usually start with whatever SSRI. It could be fluoxetine, and then, you know, refer for therapy, or give them some, you know, book suggestions or some basic guidance about that and monitor. You know, sometimes, you know, it's pretty off-label, but it's definitely off-label. But you know, sometimes in a teenager, we might, if they've ramped up the SSRI as high as we can go, and they've only had a partial response to depression, we might add bupropion. That's off-label for youth, but we sometimes do that. So it's really, you just kind of track both of those and figure out, you know, if one medication, you know, has helped a lot for the anxiety, we might then add a second medicine for depression. If we get all the way up to the max SSRI and anxiety is only 50-60% improved and depression is certainly not improved, gonna switch SSRIs, or maybe switch to an SNRI. But usually it's 2 SSRIs and then switch to the SNRI. Just kind of depends. So with suicidal thoughts, with depression, with the treatment of an SSRI, do we have to stop the medication, or you can follow closely with therapy? You can follow it closely, but that kind of depends on The family, like how much I trust the family, how tolerant the family is. Typically we tell them to stop the medication. Once the suicidal thoughts are gone, you can start the same exact medicine and it doesn't always happen again. Don't know why. You can start a different medicine. Very rarely happens again. Don't have any clue why. I've definitely had families that I've done the whole suicide spiel to, tell them stop the medication, and they don't, and then they come back to see me in 3 weeks and like, yeah, it was a rough week or two when he was having suicidal thoughts, but now they're gone. So it will go away for a lot of people, just like nausea, diarrhea goes away. So, if they've failed a whole bunch of medicines, and I think this is sort of our last reasonable, medication, or we're down to like not that many left, then I might be saying, let's just see if we can hang in there. But I really need to know that that family is watching that kid closely and not, that they've got adults with that kid's not left alone, that there's not weapons in the house, that the kid's, maybe sleeping with the parent. It kind of depends on what level of suicidal thoughts and what's the kid saying, so. Do many teens improve with, so ADHD is about as far as ADHD, and does it improve as people get older? Well, half of people with ADHD outgrow all the symptoms of ADHD by the time they're 25. So yeah, people outgrow ADHD. So when parents are looking at their kid who's 8 years old and are asking me, well, when are they going to be able to be off this medicine? I'm like, well, probably by the time they're 25. But having said that, quarter of adults who have ADHD, so half outgrow the symptoms, but still a quarter of adults with ADHD symptoms continue to take medications. So yeah, they may or may not be taking medications. It just depends on that particular person's nerve development and kind of what their trajectory is. So that. How do I feel about augmenting with aripiprazole for depression? You can do that. We don't usually do that right away. If an antidepressant is not working well, working optimally, we're going to change antidepressants probably a couple of times. Unless there's some really fabulous outcome that we feel like a family really feels like this medicine's worked well, and they were really suicidal, the suicidal thoughts are gone, the depressive symptoms are 50-60% better, they don't want to switch off of this medicine and risk going back to suicidal thoughts, then I might augment with something like lithium. You could augment with aripiprazole. Aripiprazole is FDA approved to augment antidepressants for adults. You could use Latuda, sure, we use Latuda all the time. Larisodone, that's just a different, so there are 4 or so of the atypical antipsychotics that are FDA approved to treat bipolar depression, because people with bipolar disorder are not supposed to take SSRIs. So if you worry that a kid has bipolar disorder, if you think that it runs in the family and we're not sure, there's some symptoms going on, and you for some reason can't get a consult and you're worried about using an SSRI, or maybe you've given the kid an SSRI and they've gotten activated, family history of bipolar disorder, where you're like, okay, I'm not sure if that was mania, I don't really want to take that risk and I want to use an atypical antipsychotic. You could use one of the ones that's FDA approved to treat bipolar depression in adults, which include like quetiapine, larisodone. Those are probably the best ones for you to try. I think there's also lumedeparone, but that one's probably not on the formulary. And I think that larisodone is now FDA approved down to age 12 to treat bipolar depression in teenagers. So you could use larisodone on label. Again, you may or may not know if the kid has bipolar disorder, but you'd be safe enough to use that. Larisodone has much less chance of causing weight gain as compared to other antipsychotics. So that's the reason for it. The number needed to harm in terms of weight gain for larisodone is 50. For aripiprazole for weight gain, it's 21. So you're way less. So only 1 in 50 kids who get larisodone have greater than 7% of body weight gain versus 21 of the kids with aripiprazole. So, and like 17 for risperidone. So definitely less weight gain for larisodone. So medical marijuana. Okay, is there a place for medical marijuana in this group of children? No. That's pretty much the answer. I mean, I have said, you'd have to tell me what you meant by not responding well to medications. I have some kids where I really feel like I've been through every single antidepressant, every single antipsychotic, everything that I can think. And I've said, there's zero evidence that medical marijuana does anything to help people. There's tons of anecdotal evidence, but people say alcohol helps. People think all kinds of things are helpful when they may or may not be helpful. And when we don't know what the you may feel good right now, but every open label study has a better result than a randomized controlled trial, right? And so when people know what they're getting and they have some belief that it will help them, it's always more helpful. You know, so I've told some families, I have nothing left to suggest, so go ahead and try medical marijuana if you'd like to. Almost all of them have taken it for a little while and stopped it because it's expensive and it didn't really do that much. And I've not been able to get any of them off their psychotropic medications. Yeah, sometimes it has been a little bit helpful for maybe sleep or something else, but mostly it's just an experiment the families feel they need to try, and that's okay. So, how reversible is the weight gain? Varies a lot. Some people will, you take them off the medication, the weight comes off pretty readily. Other people stuck with it, you know, and we certainly, you know, obviously we don't want people to ever gain weight, you know, to become overweight in their life in the first place, because, you know, that can worsen their basal metabolic rate, you know, for the rest of their life, you know, so we'd rather not have people get overweight. So we try to really watch weight carefully. You know, you really want to, like, if somebody's gained 5% of their baseline body weight, stop the antipsychotic, or think about what else we can do. You can add metformin, you can add topiramate. You know, is there something else that you can do? But often we switch medications. So it's really, it varies a lot. Some people the weight comes right off. Some people it doesn't. How do I handle kids with depression who come in and are also using marijuana or other substances? No, you know, SSRIs work often just fine in people who are using substances. So, I mean, it depends on the level of the substance. You know, it depends on, you know, your usual first discussion would be, I recommend you stop using the substances, right? And let's see how you feel. But they usually are not going to be very successful at that. If the family's going to get them into treatment, if they're going to get into a, you know, an outpatient treatment program, fine, wait and see how they do. But often they still feel like crap off of the substance, and you end up treating their depression or anxiety later. It's a smaller number of people where the depression or anxiety actually goes away after the substance. I mean, it kind of depends on the substance and the level of use. You know, so if the kid's going to go to residential or go to an IOP or PHP, you may want to wait. But if it's a kid who's coming to your office and you just aren't getting any traction with any kind of treatment or insight, you know, we just recommend harm reduction, reducing the amount of it, you know, educating them that this is probably not going to work as well. You know, that your treatment isn't going to be as good if you're putting all these other chemicals in. We're just going to get a big chemical fight going on in your body. But having said that, antidepressants can still help post-traumatic stress disorder, maybe, or depression or anxiety that the kid has that's there. So we you know, we often end up treating you know, the you know, that while we continue to work on getting them to reduce the substances that they're using. So other questions folks have? I appreciate everybody's time. I hope that was somewhat helpful. As far as somebody asking about the slides, I'm going to leave that up to Marie to tell us.
Okay. Well, thank you so much, Dr. Stock, for a very informative session and presentation. As we continue to try to help our primary care physicians, as we know, they're treating more and more children with behavioral health issues. So please let us know if there are topics that will be of interest to you in the future, and we will try to present them. I'm going to have two shameless plugs at the moment. If you also have questions about a medication, please contact the Florida Pediatric Psychiatry Hotline, and most likely you could get Dr. Stock to answer your questions. So please try the hotline. It's a very useful line. And also our medication guidelines or psychotropic medication guidelines are coming out in about 2 weeks. Okay. And they will be available in print and also available on our website. So we're very excited about, since we haven't had a revision since 2019. So it's been, our expert panel met last April, and we have a 404 update of psychotropic medication for children and adolescents. So please watch out for communication from our centers, which tell you where you can access them. And we certainly are looking forward to hearing from you. Please don't forget, contact us if you have topics you would like covered. Contact us. We'll be very happy to find speakers to address those topics. Thank you again.